This is QD Clinic. Hi, I'm Jack Cush with Room Now. QD Clinic is brought to you by PSA All the Way, our campaign on psoriatic arthritis throughout the month of April. Be sure to tune in starting Friday, April 1st. Our first great Tuesday night rheumatology session, which is going to run all month, every Tuesday night, 7 p.m. Eastern Time, 6 p.m. Central, 5 p.m. Pacific. We're going to have a patient perspectives, what patients say about PSA. Then we're going to have 2 journal clubs, and we're going to have a physician controversies in PSA panel. All this on Tuesday night starting this week. Watch out for the invite coming into your inbox. You can sign up for the webinar. It's 1 hour. It'll be good, I promise. Our first question. This is our sessions on questions from RNL 2022. We're going to handle questions seen during the Lupus session. We had 3 great speakers, Sonali Narain, Peter Lipsky, and Joan Merrill. I'll be taking some of their questions. Approximately when will the recorded lectures be available to view? Those of you who are registered for the event will be able to see the rehash or repeat presentations from that starting next Monday, I believe, so roughly 2 weeks after the meeting ends. Those will go up online. You'll get an email invite to that. Matt Carroll asked about what do you think about data for urinary IL-16 and lupus nephritis? I think this is the future. I think urinary biomarkers, especially for lupus nephritis, have already proven themselves to be so much better than what's currently out there. Urinary galectin binding protein we reported on today. There's other GAL markers and whatnot that are out there that have shown to be so much better than the things that you rely on. Things you rely on are actually quite horrible. They're really not very predictive at all. And that includes C3, C4. That includes the levels of proteinuria, double-stranded DNA. Again, you tilt the odds with those historic markers that you use in favor of finding active disease. But truly behaving like good biomarkers, not really. So I think IL-16, Fava and colleagues at Johns Hopkins, that was a plenary session at ACR back in 2020. Fabulous presentation, became, I think, a New England Journal paper. That looks really good. The problem is that with a lot of these urinary biomarkers, they're not yet prime time, meaning they're not on a checkbox on your lab list. But this is the future. I think we need to go there to get better management of lupus nephritis. Is there value to using Rituxan followed 4 to 6 months later with Benlysta in the control of lupus nephritis? This is from Viviane Bunin. And Viviane, I think the schedule that has been shown is that you use rituximab and then you follow it up immediately with belimumab. Belimumab is an anti-BAFF infusion, and what happens with rituximab and why rituximab probably didn't work is that when you give rituximab against CD20, you get a rebound in BAFF, and that probably negates the B-cell effects. BAFF is a B-cell activator. But then you follow it up with belimumab, the anti-BAFF, and then you sort of get the full rituximab effect and then a continued belimumab effect. And this has been the sequence. There's a number of sequencing studies that have been done. There's 3 of them that have been done in the last year, and we've talked about them. But you have to give it right away. Again, this is not FDA approved. You'd be doing this on your own in problematic patients. We had other questions about should we be studying Rituxan again? The answer is no. It failed, and I know the lupus community doesn't want to hear that. I can say that because I'm not traditionally viewed as a lupus guy, but it didn't work. It didn't work in my practice before they did the trials, and there were problems with the trials. I think rituximab may work if used in combination or other B-cell, and we're waiting for obinutuzumab, another B-cell inhibitor that looks better than rituximab. Those are the trials you're going to wait for, but I think they really might need to be in combination to do what's been done in these 3 sequencing studies that have been done, and that would include the SynBios study, which we talked about. That's SYNBIOSE if you want to look it up. Do you use Acthar gel in any special cases? Nope. Never, not going to do it. No studies to support it. It's grandfathered in. It's $1 bazillion for a steroid effect that costs 12 cents. Sorry, folks. In what subset of patients would you use either voclosporin or belimumab in lupus nephritis patients who failed standard induction therapy with cyclosporin or mycophenolate? Good question. Hard question. This comes from Alina Flagg. I think that it's pretty simple. I think it boils down to whether you're a believer in belimumab and you have experience, or a believer in voclosporin and have experience. I find it interesting, as someone who does clinical trials and my colleagues and peers at clinical trials, the people who did the developmental trials for drug A, for instance, are more likely to use that drug A in their clinical practice when that drug becomes available. I did the trials in drug B, and so I'm more likely to use drug B. I think this decision of belimumab versus voclosporin, two different MOAs, both have been shown to work in lupus nephritis. I think belimumab's an IV, and has and the responses to infusion, I think, are a few months. Not right away with their first infusion. I think that voclosporin could be considered, and that's an oral medication, and the responses might be a hair sooner than belimumab. But I think it does boil down to your experience and whether you want an infusion or an oral medication, and how you're going to monitor these patients, what you're going to worry about. Voclosporin looks like it's very safe. Belimumab certainly looks to be very safe. I could advocate for both of them in patients who didn't respond to either Cytoxan or mycophenolate. Any pearls from the panel on diagnosis of neuropsychiatric lupus, and especially MRI or CSF evidence or anti-neuronal antibodies? I'm a self-declared expert in this area, and I studied this a lot. Not much has changed in this from when I was a fellow and when I was doing practice 10 and 20 years ago. I think it's neuropsychiatric lupus is a diagnosis of exclusion. And here's the way I think about it. A lupus patient gets admitted to the hospital. We're not talking neuropsychiatric lupus. Lupus gets admitted to the hospital. They're more likely to be admitted to the hospital for a medical problem, an MI, pneumonia, a blood clot, a side effect of medicine, than to be due to lupus. This is more commonly the case. This is what almost 40 years of practice has shown me. On the other hand, a lupus patient who gets admitted to the hospital with a CNS presentation, it's more likely to be neuropsychiatric lupus than it is going to be a medication problem, steroid psychosis. I only seen like one of those in my career, or the effects of uremia or a secondary or another infection. So your obligation here is to exclude, again, medical causes, drug causes, concomitant causes, and then neuropsychiatrics, a diagnosis of exclusion. And so there is no one diagnostic test. MRI, generally not helpful if you're getting readings of looks like vasculitis. That's a pipe dream. That's a hope. That's not really, there's nothing diagnostic. Vasculitis is increased signal in a pattern that could be due to gliosis as much as inflammation. And in fact, in neuropsychiatric lupus, there is no vasculitis. There is no inflammation. When biopsies were shown bland vasculopathy that looked like what? High blood pressure more than anything else. So MRI mainly to exclude, mass lesions, other causes, stroke, blah, blah, blah. Okay. You're not going to do better with other imaging modalities. There are some people who want to talk about PETs and SPECts and whatnot. I don't know that their utility has been proven, and especially in a cost-effective manner. Your best tool is going to be either EEG if you suspect any seizure activity, or CSF studies. The CSF gives you what? Most are fairly benign looking. Some show a minor lymphocytic pleocytosis. So tube number 4 can have 4 to 10 cells. You don't get back 100 WBCs, all of them being lymphocytes, in a CSF of a lupus cerebritis patient. That's pretty unusual. About 20 to 30% will have a lymphocytic pleocytosis. Ordering protein is useless. Ordering glucose is useful because there are patients who have very, very low glucose levels in the CSF, and that can be due to infection or can be due to lupus cerebritis or neuropsychiatric lupus. I like ordering, you can do Anti-ribosomal P, that's a serum test. Doesn't really perform any better in the CSF. Antineuronal antibodies, I have done plenty of. I've never found them to be useful. I've done plenty of immune complex tests on CSF. Again, if they come back positive, it's useful. But how many boxes are you going to check on a limited sample of CSF that you have? I mean, you can't do every test. So I tend not to rely on those because they don't have a very poor return. I think what I'm looking for are abnormalities in the Q albumin and in the IgG indices. So the Q albumin is a measure of CSF to serum albumin measures. It's a CSF albumin times 1,000 divided by the serum albumin using the same units of measure. Normally, you and I, the Q albumin is less than 9. If it's greater than 9, that means that there's an abnormal blood-brain barrier. It's no longer intact. Turns out that about 30, 40, 50, sometimes 30, 40% of patients with lupus cerebritis will have an elevated Q albumin, but only as high as 15, 9 to 15. Beyond that, when you see Q albumins of 30, 100, 200, that's vascular events and infection. So you want a Q albumin that's in line with cerebritis, meaning it's normal or it's minimally elevated. Next, you want to see in situ production of immunoglobulin. That's the IgG index, IgM index, if you like. However, that test is not valid if the Q albumin is elevated or abnormal. Again, if the Q albumin is like gigantically elevated, like, again, 30, 50, 100, 75, whatever, then you got other problems and not lupus cerebritis. But if it's minimally elevated or normal, then you need to use other tests that correct for the abnormalities that occur within a non-intact blood-brain barrier. So that's called, people do the synthetic rate. That's actually affected to some degree. There's other measures called the IgG-LOC and others. But again, the higher those abnormalities are, then the more you can assume there's a significant amount of in situ production of immunoglobulin, meaning that there's an immune-mediated process going on in the brain. Again, all told, I think I can account for 40 to 50% of neuropsychiatric lupus just based on the CSF. I can get a few more percent based on the imaging. And then I'm just left with a whole bunch of patients who I just have to assume it's neuropsychiatric disease, and half of those will respond to steroids, not too quickly, unfortunately, and half of them won't, and you're not going to know the answer. Again, I think talking to someone who sees a lot of neuropsychiatric lupus may help you. 2 more questions. What's the clinical relevance for a positive RNP antibody, but a negative ANA? I think I would worry about, Raynaud's, lung disease, MCTD, but you can't have MCTD without having a very high titer ANA. You see these patients, but I think I'm not doing tests on patients who don't have symptoms. I'm not ordering serologies to fish for clinical correlations. That's the wrong way to use these tests. Lastly, what's the info available regarding an ANA following COVID-19? During acute hospitalization in COVID-19 patients, 50, 60, sometimes 70% of patients have ANAs, antiphospholipid antibodies, and whether they're involved in the pathogenesis is not entirely clear, but they do stay, and they do stay for as much as 6 months. So if they're post-COVID and they're within 6 months, I don't know that I would order an ANA or any serologic test unless I was looking for that diagnosis: myositis, scleroderma, lupus, etc. To show that they still have ANAs or antiphospholipid antibodies lying around, what are you going to do about it? Are you going to treat a lab test? Hopefully not. That's it for QD Clinic. Tune in tomorrow. We have more questions tomorrow, probably about ankylosing spondylitis or hot topics. You'll see.